Good afternoon, everybody, and thanks for staying too late today. I guess that everybody is super tired, and I appreciate to have you all here in this room. I am really honored to be in this panel. I have to say that it's my first time chairing a panel, then apologizing. I'm gonna be, and I made you be crazy during all these days, and thank you so much for your patience. I don't want to take a lot, but I want to introduce myself. I'm Roig, Director of Medicineres. I have been working in different consumption rooms in Barcelona, in Canada. I began the programs for people who inject drugs here in Colombia, and I contributed to the model, the harm reduction national model in Costa Rica. Then when I came back to Barcelona, I opened up Medicineres that we don't define as a consumption room, but we incorporate the consumption inside our community place. That is, I think that is one of the evolution that the consumption room can have, and is one of the topics that I would like to discuss with you. And I'm gonna introduce each speaker, each one. Then I'm really honored to introduce Alfonso. Alfonso Chavez is the coordinator of the harm reduction program at Prevencasa, de la Zona, that I was there. I had the privilege to visit, and I have to say that I was amazed how it feels as a home that prioritizes women, the safety of women and trans people, and the creativity and the challenge that you have to do, because one of the things that gets stuck in my head is how you have to cross the border just to have the basic supplies to run the consumption room. Then thanks a lot for all the work, and yeah.
Hola, buenas tardes a todos, todas. Muchas gracias por estar acá presentes. Muchas gracias, Aura, por la introducción, y a todos los que nos acompañan el día de hoy dentro del panel y ustedes. Voy a hablar en español, entonces anticipo para… Hágale. Bueno, la Zona es un espacio seguro en Tijuana, México. Es uno de los servicios que incluye la organización a la cual trabajo o pertenezco, que es Prevencasa. Y para dar contexto, primero voy a situar dónde se encuentra la organización y qué es lo que hacemos. Siguiente, por favor. La organización comienza en el 2004. La ONG es una organización de base comunitaria que está ubicada en la zona de tolerancia de la ciudad, la zona norte, que es donde crecí, a la cual pertenezco y pertenece mi familia. Se caracteriza por tener o albergar a personas en contexto de movilidad, personas con drogas en vía pública, ¿no? Consumo en vía pública, muchas deportaciones provenientes de Estados Unidos, habitantes de calle, uso de sustancias en vía pública, como lo comentaba, y muchísimos albergues para migrantes, ¿no? El trabajo sexual y el turismo de drogas están muy presentes. Para citar un poco más, Tijuana se encuentra al norte de México y hace frontera junto con Estados Unidos. Entonces tiene dinámicas sociales muy particulares, a diferencia del sur del país. En la zona norte de Tijuana, en la frontera, se concentra un grupo muy alto de personas que consumen drogas inyectables. El Chaparral, por ejemplo, que es el cruce fronterizo entre Tijuana y Estados Unidos, es el más transitado en el mundo, con más de 30 millones de cruces por año. Para poner un ejemplo y conocer un poco o dar en cuenta las dinámicas que existen en esa frontera. Siguiente, por favor. Bueno, el programa empezó hace casi 20 años, sin embargo se ha ido introduciendo múltiples servicios dentro de este espacio, y es un enfoque, digamos, con un inicio muy clínico al principio, solamente abordando el tema de VIH, pero a lo largo del tiempo se han ido incluyendo otros servicios, los cuales pues incluyen las jeringas, las pipas, aluminio, la atención médica, ¿no? Pruebas rápidas de VIH, sífilis, hepatitis C, un modelo de atención de cuidados de heridas y abscesos, acceder a información. Ayudamos mucho a tramitar de alguna forma documentos oficiales para las personas que son deportadas, porque muchas personas no tienen documentos oficiales y quedan expuestos o expuestas a múltiples atropellos a los derechos humanos por parte de las autoridades. Trabajamos mucho en talleres comunitarios, derechos humanos, autocuidado, prevención, sobredosis y el cuidado veterinario para mascotas. Tenemos algún voluntariado de amigas que vienen y dan cuidado a las mascotas de las personas que están en condición de calle, que es también un elemento que a veces olvidamos, pero que es importante, ¿no? Siguiente, por favor. Bueno, contextualizando un poco, la comunidad detectó fentanilo desde el 2017, 2018, y digo la comunidad porque no fue ni las nuevas guardias de seguridad, no fueron ni la policía municipal, ni las aduanas, ni los puertos, sino fue la misma comunidad que empezamos a ver una transición de la sustancia, de lo cual teníamos heroína goma negra, y la transición hacia una nueva sustancia que era un polvo blanco, ¿no? Lo cual con la ayuda de Jaime, quien está ahí al fondo, nos ayudó a introducir un modelo de detección de adulterantes dentro de las sustancias con tiras FTIR, que creo que las tienen bien familiarizadas, y pudimos lograr fentanilo, ¿no? Detectar fentanilo en la droga local. No hay datos oficiales por sobredosis. Como les comentaba, tenemos mayor presencia de seguridad pública, la Guardia Nacional, el Ejército, Policía Municipal, Estatal, ministeriales, etcétera, etcétera. Hay más testimonios de atropellos a los derechos humanos, están las limpias sociales, es una constante, es una política que implementa nuestro país, especialmente donde hay personas en contexto de calle y hay desapariciones forzadas, y lo nombro así porque después se omiten ciertas palabras, hay que decirlo, hay gente que no volvemos a ver después de estas limpias y nadie pone cara ante eso. Las personas continúan estando muy lejos de las instituciones, no se acercan a las instituciones de salud pública, etcétera. Y bueno, con decirles que tuvimos 1 año y medio sin metadona en el país, ¿no? Entonces, todo este tipo de violaciones y tipos de políticas de drogas en nuestro país son una constante. Sin embargo, la organización tiene un subregistro de más de 900 sobredosis atendidas por lo menos en 2 años. Entonces, la siguiente, por favor. ¿Qué pasa con la naloxona cuando hay tanto número de sobredosis en México? El gobierno ha dicho que bueno, que por un lado no hay un tema de qué preocuparse, incluso no hay existencia de naloxona en farmacias locales, hay un alto costo en internet y pues está fuera del servicio de la comunidad. Alguien no va a pagar $50 por un servicio de internet, ¿no? Para tener acceso a una naloxona. Incluso pues nuestros políticos, el expresidente anterior dijo que digamos, la naloxona está clasificada una como un psicotrópico en el país, ocupa uno una receta médica para tener acceso a él, y si lo portas sin esa receta te puedes meter en un problema legal. Otra, incluso el expresidente anterior dijo que bueno, la naloxona solamente prolongaba la agonía de las personas, entonces por eso no era necesario tenerla. Sin embargo, miren, las mismas autoridades, Cruz Roja, bomberos, policías municipales, vienen a pedirnos naloxona, ¿no? Eso es una locura. Y bueno, yo siempre he dicho que en mi país las políticas y la incidencia se hace en la calle y no se hace a través de los magistrados, etcétera. Siguiente. Al iniciar, yendo directamente al tema del espacio de consumo, la adaptación duró más de 1 año, empezamos a gestionar este nuevo espacio y lo más importante, creo que muy pocas veces se habla de los procesos, de a quienes involucramos y quienes nos acompañan en estos procesos tan interesantes, ¿no? Entonces, con la ayuda de 3 personas de la comunidad empezamos a adaptar el espacio. Se hizo un flujograma y bueno, hicimos algunos focus groups con algunos temas muy relevantes. Hicimos alguna evaluación de riesgos con mujeres que se inyectan drogas, por ejemplo, y las dificultades que tenían al momento de utilizar inyectables en vía pública, y resurgieron muchísimos temas sobre abusos, sobre temas policiales, falta de insumos, etcétera. Servicios adicionales, y qué otros servicios adicionales se podían integrar a este espacio. Es un modelo que tiene un reacomodo, una reorganización del espacio. Si bien las personas quienes pueden tener este espacio regularmente son personas que están en calle, que no tienen una apropiación de ningún lugar, que son movidas forzosamente o desplazadas forzosamente. Entonces lo que queríamos era justo que las personas se apropiaran de este lugar, que ellos pudieran acomodar el lugar como ellos quisieran. Si ven, al inicio van a ver en varias de las fotos la mesa acomodada de un lado, después acomodada a la otra esquina, después, ¿saben? Y eso significa que pueden mover el espacio a su gusto. Así empezó. Yo empecé a supervisar el espacio porque no había personal para hacerlo. Empezamos a promoverlo, a circularlo en el barrio, en la comunidad. Y bueno, la zona, el sitio de prevención de sobredosis, como le llamamos, el sitio de prevención de sobredosis tiene dos funciones. Una es para inyectables, puede ser heroína, metanfetamina, cocaína, etcétera. Y otra es área para fumar, que no tenemos extractores, simplemente es un espacio y aventamos el humo hacia arriba, ¿no? Y eso es nuestra área para fumar. No nos hicimos más tema, el espacio está adaptado con lo que tenía la organización, con los muebles que estaban ahí guardados, se instaló el servicio. Hay algunos manuales, están impresos para las personas, cómo revertir sobredosis, cómo testear la sustancia, cómo preparar la pipa con metanfetamina y algunos otros cuidados personales. ¿Qué insumos se están facilitando en este espacio? Bueno, hay un área de inyección, les decía, de fumar, área de descanso, la gente tiene un área de recreación, hay un almacenamiento de pertenencias, pueden dejar sus cosas, podemos guardarlas por cierto tiempo, y justo es también algo que surgió de estos focus groups. Hay pues limpieza de heridas, ¿no? De abscesos, está el área de maquillaje comunitario, los viernes tenemos proyección de películas, compramos pizzas y podemos pasarla bien. De repente también olvidamos esos otros temas también que son muy importantes, ¿no? Como alguien que tiene una casa, el privilegio de tener un techo, llegar y echarse y ver una película, y de repente alguien te dice, no, yo tengo 5 años sin ver una película, ¿no? Entonces eso de alguna forma ha hecho que todavía se acerquen más, ¿no? Y hagan uso de este servicio. Talleres, atención sobredosis, derechos humanos, el autocuidado y el apoyo a la mujer también. Algunos insumos, como ya les había mencionado. Y bueno, dentro de la organización vinculamos a otros servicios como regaderas, duchas, consulta médica primaria y consulta psicológica. ¿Qué ha pasado a más de 2 años y medio? Pues ha habido más de 2.200 usos del servicio por más de 186 personas diferentes. 76% de las personas son mujeres, 20% hombres. Ojo, los hombres que entran acá solamente son hombres que las mujeres nos indican quiénes pueden entrar, o sea, esos acompañantes de confianza, ¿no? 4% de la población trans, el 59% usa drogas inyectables y el 40% utiliza el espacio para fumar, que eso es una parte importante, promueve el aluminio y los cambios de prácticas de consumo para riesgos o minorar los riesgos, pero no les provees el espacio. Creo que eso es también muy, muy importante. Lo mismo, 85% de las personas están consumiendo heroína en polvo blanco, heroína goma negra, metanfetamina. 99% de las sustancias reportadas como China White y goma negra han dado positivo a fentanilo y el 50% de las muestras son positivas a psilocina. Bueno, algunos, solo para cerrar, algunas de las reflexiones muy, muy generales. Las personas no necesariamente están entrando al espacio a consumir, ¿no? Simplemente pueden llegar, descansar, dormir un rato, pueden escuchar música, pueden maquillarse, se alistan, se bañan, se van a trabajar. Hay una necesidad de expresarse, por eso justo hay énfasis en esta área de arte y de esta área de trabajar temas más recreativos. Y también se entablan conversaciones que no se pueden tener en la calle. Hablan acerca de drogas, de puntos de venta, del autocuidado, de violencias, de recomendaciones, de prevención de aquel cliente, ten cuidado con aquella persona, etcétera, de temas de violencia dentro de las calles también, de los abusos policiales es una constante. Entonces yo siempre pongo esta reflexión cuando empecé a a supervisar el espacio. La primera persona que entró fue una amiga, Sujei, y me recuerdo que le pregunté qué canción quería escuchar, le puse una canción, se sentó, estaba en la mesa, tomó su jeringa, preparó su sustancia y se inyectó y me dijo, me agarré a la primera, ¿no? Y ese agarrarse a la primera para ella significaba no estar en la calle expuesta a un entorno de violencia, de que viene la policía, de que me están persiguiendo, de que alguien me quiere robar la sustancia o miedo a consumir, quedarse dormida y que la fueran a violar. Entonces siempre se me quedó como esa frase muy grabada, ¿no? Siguiente. Y bueno, no, creo que ya no se puso. Bueno, y también dar gracias a todas las personas que nos han visitado ahora, quienes han estado ahí, también son una fuente de inspiración. El intercambio de conocimiento, el intercambio de modelos es bien importante para nosotros. Y bueno, sería todo por mi parte. Muchas gracias.
Muchas gracias, Rocha. De tu presentación, destacar, ¿no?, cómo a veces la medicalización, la institucionalización acaba criminalizando el salvar vidas entre iguales, pero que luego vemos que somos la primera respuesta igualmente, ¿no?, los espacios comunitarios, porque llegamos donde nadie más llega. Me encanta también empezar contigo, porque creo que también es una manera de enseñar lo simple que puede ser un espacio de consumo acompañado. Lo llamemos Supervised Consumption Rooms, lo llamemos Overdose Prevention Sites. Es un espacio donde las personas pueden estar acompañadas, se sienten aceptadas, ¿no? Y basta con 2 mesas, sillas y mucho amor, ¿no?, y mucho cariño. Y a partir de ahí empezar a complejizar, pero sobre todo para espacios comunitarios y hablando aquí en Colombia, ¿no?, la importancia de no generar esos grandes centros que son carísimos y que no llegan, que son bastante difíciles de aplicar en la mayoría de lugares, ¿no? Y que cuando los hacemos que sirvan de ejemplo para innovar muchísimo y dar esa, ¿no?, esos datos que desde las pequeñas no podemos recopilar tanto, ¿no? Y lo último de destacar de tu presentación es ese derecho al bienestar, al ocio, al descanso, a la diversión, ¿no? Cómo de revolucionaria y terapéutica es la alegría, ¿no? Y gracias por esa presentación. Y sin más, pasar a Piper, que no nos conocíamos antes. I'm gonna shift to English so she can understand. Sorry about that. Then Piper is the clinical research coordinator at the British Columbia Centre for Substance Use. She's going to present on the hospital-based inhalation overdose prevention services in Vancouver, which I feel that is really quite interesting because when I was working at Inside, for a while, it was one of the main challenges was how we could open an inhalation room, no, and how we could manage that. Then I'm so glad that finally you could do it.
Just grabbing my notes, 1 second. All right. Good afternoon, everyone. My name is Piper Dickhout. I'm a clinical research coordinator with the BC Centre on Substance Use. And today I'm hoping to share with you the incredible and novel work that the Overdose Prevention Site team has accomplished, and specifically the hospital-based inhalation services at the Overdose Prevention Site in the hospital in Vancouver, British Columbia. I would also like to first acknowledge the land in which this work has been conducted on, which is the never ceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations in so-called Vancouver, Canada. Next slide. Oh, nope. All right, so first off, I wanted to provide some regional context of the drug supply and the unrelenting public health emergency that is due to the toxic drug supply in BC. We are currently in year 9 of the declared emergency, and this is due to the presence of synthetic opioids, benzodiazepines, and sedatives that greatly impact the mortality and morbidity of Canadians. So much so that approximately 51,000 Canadians have died since the declaration in 2016. As most of you are quite familiar, the main drivers of this crisis are the toxicity of the drug supply and the persisting prohibition and criminalization of substances. Next slide, please. All right. On the provincial level, over 16,000 British Columbians have died due to the toxic drug supply. This average is to about 7 deaths per day. In an effort to mitigate these devastating harms of the crisis, it is important to acknowledge that grassroots efforts have really paved the way to for rapid scale-up of harm reduction initiatives such as overdose prevention sites, or OPSs, to allow people who use drugs to use substances in a safe and secure environment. Next slide, please. And due to historically abstinence-based hospital policies in BC, patients have had to resort to engaging in risky substance use behaviors such as sharing needles or using alone in the hospital washroom to adequately treat pain or withdrawal symptoms. As a result, people who use drugs are up to 3 times more likely to self-initiate their discharge before their hospital care is complete. In 2018, as a harm reduction initiative to allow for safe consumption of substances on hospital grounds, the St. Paul's Hospital in Vancouver opened the first hospital-based nurse and peer-led OPS in North America. In December of 2020, the OPS moved to a space in downtown Vancouver, BC, that it was near the hospital, but clients shared that this created a service gap for patients that cannot leave due to feeling unwell or other circumstances. And so by February 2021, St. Paul's Hospital addressed this gap by opening another OPS on hospital grounds and was expanded later in 2024 to include inhalation services in addition to injection. So next slide, please. Okay. And so expansion of these services was initiated based on 3 main factors. First, the evolving needs of patients, where the increasing toxicity of the supply and notable shift towards inhalation as the main route of consumption demonstrated the impetus for expanding the OPS to include inhalation services that was originally in an injection-only service. Second, in the year preceding expansion, Code Blue calls in response to suspected drug poisonings reached an unprecedented high of 96 calls, or a total of 922 minutes of healthcare provider Code Blue response time. Staff also reported less than optimal work conditions due to being in an uncovered space. In other words, inclement weather such as snow in BC really impacted the safety of both staff and clients during an overdose response. Lastly, in May of 2024, the provincial government implemented the Substance Use and Addictions Management in Hospital policies, forbidding the use of substances, personal substances outside of a designated OPS. And as a response, the St. Paul's OPS team was approved in a tight timeline of 11 days to build, hire, and create policies for inhalation services that had never been offered in an acute care setting in North America. And man, did they pull it off. Here are some of the pictures on the left here. And next slide, please. And so the St. Paul's OPS has shifted to a peer-led operational model where 6 peer support workers or peer witnesses and 1 peer coordinator, all with lived and or living experiences, are leaders on shift, while clinical support is directly integrated into the hospital system and is provided by a clinical nurse educator. Next slide, please. Moving on to the physical environment and services offered. The new OPS provides a more social layout to use substances together and connect with community while also having direct integration into a hospital setting. This is with access to a Code Blue or critical access or critical care team. This team consists of 2 nurses with advanced cardiac life support training, 1 intensive care unit physician, and 1 respiratory therapist. Whereas in comparison, community-led based OPSs currently rely on calling emergency services with basic life support training to respond to the event of a drug poisoning emergency. Other services include witness injection and inhalation, take-home naloxone kits and training, safe drug supplies and disposal, peer support services, harm reduction education, and finally testing services to detect fentanyl and benzodiazepines. Next slide. So here are some photos of the space. On the left is the check-in space where clients will come in and check in for their time there. And then on the right is the injection space. Next slide. And here is the expanded inhalation spaces with the community chairs for socializing and gathering. Next slide, please. Given the novelty of this service being in a hospital setting, the Ministry of Health provided our team a timely opportunity to evaluate the expanded scope of the OPS services. And our goals were really to describe the trends in the uptake of inhalation services, also to characterize the uses and experiences of the clients, and then finally report any adverse events such as code blue calls in the response of an overdose. And we use Code Blue database and program metrics alongside quality improvement, client and staff surveys to achieve this. Next slide. So the saturation is off on my end, but hopefully you can see some of the results here. And these are the program-specific measures as of April 8th, 2025. Notably, we observed 83% of clients' primary route of consumption was inhalation. And on average, there was 36 visits per day with a total of almost 12,000 visits since the expansion of services. Next slide, please. Following the implementation of the inhalation services at the OPS, there was a 62% reduction observed in overdose-related code blue events. And correspondingly, we saw a 65% reduction in total code blue response time. So 922 minutes, like I mentioned before, in the pre-implementation phase versus 324 minutes in the post. Lastly, there has been a 60% decrease in reports of people using substances in areas of the hospital that aren't the OPS. Next slide, please. And so moving on to client satisfaction, we surveyed 100 participants or clients and observed the majority of them to be white and identify as a man. Nearly 2/3 of clients were inpatient, while the rest came from the emergency department, outpatient services, or as an essential visitor. On the right is the distribution of primary substances consumed, with fentanyl being the highest and cocaine and fentanyl that was sought out with suspected contaminants such as benzodiazepines were lowest. Next slide, please. Now, on to the more exciting data, in my opinion. Looking at the perceived impact of having an OPS on hospital grounds, 84% agreed that it had decreased their overall risk of overdose. And clients also endorsed that the OPS provided a safe space to use substances, where 51% reported that it prevented them from using alone, and 45% reported that the OPS prevented them from leaving the hospital early or self-initiating their discharge. And lastly, 38% reported feeling motivated for treatment and recovery after having access to the OPS. One of the most highly reported barriers to accessing the St. Paul's OPS was the overnight closures. As it stood, the OPS was only opened for 8 hours a day. But as a response to this identified gap, the OPS team will now be working, and the OPS will be running for 16 hours a day starting this spring. Thank you. Next slide, please. All right. And finally, I would like to share some of the staff satisfaction results, as ensuring staff well-being is crucial and vital to providing exceptional care. And so here are some of the demographic information. We surveyed 23 staff members, primarily in the role of a peer support worker or peer witness. And we also then surveyed nurses, a coordinator, and an operational leader. 65% of staff identified as women, and 86% identified as white. And below on the first table, you can also see the varied distribution of work experience in the substance use care field prior to entering their role at the OPS. Next slide, please. And excitingly, 95% of staff agreed that they were satisfied with their job overall, and reported processes such as protocols for code blues, providing harm reduction education, connecting to community services and resources, finally capturing service access data were reported to be efficient. One of the most important additional supports that would aid staff in their roles reported to be mentoring and training opportunities, and additional supports that would aid in ensuring a culturally safe environment for Indigenous participants who are in Canada disproportionately impacted by the overdose crisis and have historically faced discrimination in the healthcare setting. Next slide. And that's it. Thank you.
Thank you so much, Piper. I would like to highlight how important is to provide these huge these services that really go where the people are at, and especially in the hospitals. We know that one of the main things is that people can finish the treatment and they don't have to leave because they use drugs, which is crucial. And also the inclusion of the hospital in all this perspective, how brave is it? And I think that it reflects the context of Vancouver, no? And I want to mention that you always have been pioneering on harm reduction in that city, and you still are. And I want to mention also Jeremy that was here with the Dolph and the Say Supplies fight, that I think that complements all of this and that we need to remember also. Thank you so much, Piper. We're gonna go to Mike Selick, that gonna explain us a new experience, no? That I think that you had good news. Then he's gonna talk about the Overdose Prevention Center in Burlington, in Vermont. He's the Director of Capacity Building and Community Mobilization at the National Harm Reduction Coalition. Thank you so much for being here.
Thank you. So first off, I'm really struggling with altitude sickness. So if I forget what I'm saying, lose my train of thought, or say something you dislike, let's blame it on that and nothing else. Thank you. So as was said, I'm Mike Selick. I've worked at the National Harm Reduction Coalition for almost 10 years. Before I worked here, I was the Director of Services at St. Anne's Harm Reduction in the South Bronx in New York City. And before that, I actually worked where Sam now works at On Point, New York, doing all of the peer training, peer outreach, and policy work for that organization. If you don't know who we are, I have a clicker, I gotta remember to do that too. We're the National Harm Reduction Coalition. We're a United States-based organization. We started 30 years ago this year, and we were basically some of the syringe providers in the few cities that actually had programs back in around 92, and we realized we want to get this everywhere. So we started doing policy work all over the country, trying to make sure we could change laws so that every state, city, community could have a syringe program. Then we realized if you've never done this before, you might not know how to do it. So we do a lot of trainings, technical assistance to teach you the best way to possibly do these services so that you can deliver the best services that we have. Many of you, especially those from the US, probably know us best from our conference. We do them every other year. They're pretty great. Other than this conference, I'd say this is maybe my favorite conference. Ours is my second favorite. So if you come to the US, when we do the next one, it's a lot of fun. We also do a ton of overdose prevention work. And if you check out our website, harmreduction.org, we have tons of resources, publications, reports, other fun stuff, webinars, things you could check out. I almost said next slide while hitting the button. So what even is Burlington? And this is not just a question for international people. I would bet most people in the US have no freaking clue where the hell I live. And there's a reason for that. We're a small college town in northern Vermont. We're not near anything. The only place to go is Montreal. See, there you go. Brain farts. Montreal, Canada, because that's about an hour and a half from me. We have a population of 55,000 people. Very homogeneous. It's almost all white, middle, or upper class people. The a little bit about Vermont. We have the second highest rate of homelessness in the entire country after California. And a significant portion of that lives in Burlington because we're the only city, if you can call 55,000 people a city. I'm from Brooklyn. I don't know if it counts. But anyway, I moved to Burlington about 5 years ago. And this picturesque downtown in the minds of the media and many Vermonters is the epicenter of crime, homelessness, drug use, and overdose. Even though the city has very, very low rates of violent crime, I think there were like 3 shootings in 2021 and everyone freaked out. And then I don't think there's been another one. And once again, I'm from Brooklyn. That's not crime. I don't know. Vermonters. But like, who are we? Have you ever heard of my state? Probably not. I'm going to talk about the 3 most famous Vermonters in hopes that it maybe sparks something that you've heard of my city. So we got this guy, Bernie Sanders. You've likely heard of him. Maybe the only Vermonter you've heard. Oh, I'll take a clap for him. Our federal representatives are amazing. Oh, I didn't do the thing, so no one sees the picture. Thank you. Yeah, all right. I was wondering why no one thought my meme was hilarious. That makes so much more sense. So he's one of our most famous residents. He's our former mayor, if that gives you a little bit of a perception of what the politics of my city are like. The next most famous people from my city are Ben & Jerry's. They started their ice cream shop in an old gas station downtown. Now they own a multi-million-dollar, multi-continent, whatever. They actually don't run it anymore, but if you've looked at the flavors, they're all hippie flavors, and they run a wonderful foundation that donates to progressive causes across the world. And then finally, the band Fish, who went to the college in my town. I don't particularly like their music, so I don't really want to focus on them. I'm sorry to all the Fish heads out there, but they're like a hippie jam band, whatever. Basically, what I want you to take away is our town is filled with white hippies and like white elderly queer people and college people. So that's the context by which you can understand the politics and what goes on in Burlington, Vermont. As a small city, our data looks very low. Coming from other bigger places, we don't have a ton of overdoses. When you think about how few people live in the city, the numbers look bigger. It's never really crossed over 30 a year. However, there are lots of overdose survived. Almost all of our drug use and unhoused people live within 10 blocks of the small downtown that I just showed you. They're usually either in City Hall Park, the church across the street, or injecting in the parking garage. So we have lots of funding for firefighters to get in the park and reverse overdoses. I tried really hard to get the mayor to give it to peers to do it because the firefighters suck at it, but they do save a lot of lives even if they're kind of dicks while doing it. So we have hundreds of overdoses that are survived every year, which is wonderful. But the catchment area of an OPC would be wonderful in a city this small because most people are probably using outside in an alley 3 blocks from where our center will be sited. God, I hope so. So more about the political climate. In 2020, we're one of the only cities in the entire United States who defended the police. I mean, well, sort of. Our city council decided not to rehire police as they quit to lose people by attrition. And then as a result, the former mayor and the police chief engaged in significant propaganda to place articles all over our news about the 3 aforementioned shootings, the rampant drug use and homelessness all over the streets. Meanwhile, the governor evicted everyone from the hotels as soon as the federal funds ran out, so that's why there are people in the streets in the first place. So this has really shifted the political window over the years. You can't go to a city council meeting without some NIMBY complain about seeing needles on the street. I just want to make it clear that, yes, there's a national backlash against harm reduction. My city is not some haven where harm reduction is loved by everyone, but we've been educating our legislators for so long that they kind of can't hate harm reduction. Even when they talk about needles on the street, they still have to say, we know it saves lives, but, and then I show up and tell them their butts don't make any sense. Vermont also has a Republican governor for over a decade who runs largely unopposed. I don't know why. The Democrats don't run somebody. This guy is not great, but he's not Trump, so everyone thinks he's pretty okay. That being said, he's vetoed every harm reduction bill we've ever passed, so he's a huge obstacle to actually making progressive change in our city. So how do we get this through? We passed this bill to get an overdose prevention center 3 years in a row and got it vetoed every time. Last year, we temporarily had a supermajority of progressives and Democrats, so it was vetoed. We just were able to override the veto. And how do we do that? I mean, it's not rocket science. You probably all get it. You have to talk to your legislators for 10 years straight. Everybody who's ever been elected to city council in Burlington has met with someone from our coalition, a person who uses drugs, a person who provides services, to be exhaustively told what harm reduction services are. I was at a city council meeting where somebody said, I've read some of this data. I don't think these overdose prevention centers will even end overdoses. And then one of our city council members responds, well, I read that in the area of like 10 blocks. It's pretty darn effective, and our whole city is 10 blocks. So I think this is actually really perfect fit for our city. During the Senate floor debate for the bill, our senators sounded like they were my coworkers. They were so well informed on this, and this is just because coalition worked for years, and big shout out to DPA who hired some lobbyists for the last year to really help us get over the line. But this bill would not pass this year. We lost the supermajority because they raised taxes on schools and everyone freaked out. Vermont is a very poor state. We very much rely on federal funds to exist. And because we have a Republican governor, we have a very conservative health department. They do not like harm reduction that much, but kind of have to pay lip service to it. The Commissioner of Health has testified repeatedly against OPCs. He got in a fight with me about whether or not prior authorization for bupe makes sense. Context, that just means you can't get the drugs on demand. You have to go through your health insurance and wait and delay. So he's not the greatest health commissioner in the country or anything like that. Thankfully, he's retiring. So, I mean, the same governor is going to appoint someone, but it can't be worse, probably. All right, I was going to say next slide again. So, I got it. I think it's my last slide anyway. So how do we do it? Almost a decade of advocacy. We've been taking trips to the state capitol. We got media coverage of overdose deaths, how OPCs can prevent overdose deaths. We do Overdose Day, Awareness Day events. Vermonters really care about neighborliness. It's like something that is ingrained in them. So we talk a lot about like, these are our neighbors dying, like these are people from our community. Yes, the fact that the people dying look like the richer people in town probably has something to do with it. But I just want to be clear that I don't think that is necessary or sufficient to win this campaign, but it certainly is helpful. What makes it win is by talking to the legislators over and over again. We ensured the Opioid Settlement Board. I don't know how much context I have to give here, so I'll try to give a little. The government of the US has sued opioid manufacturers to get lots of money for overprescribing that I don't really think is a thing, but we don't have time to go into that. But we do appreciate the money. So we went to every city and town to make sure that everybody appointed somebody with lived experience who loved OPCs onto the Opioid Settlement Board, because that was going to have a lot to do. There was no way they were going to use tax dollars to pay for this. That wasn't going to happen. We needed that money or we were going to have no funding. We brought in experts from around the country, including, nope, not even going to try, blanking on his name, from Brown University. And Kaylin from On Point came out a bunch of times to educate our legislators. Just really wonderful resources to hear. One, like it's not just these weird group of people in Burlington, but like this is based in reality of research from across the world. And finally, we got, I already said this, we got a bunch of support from DPA, which was wonderful. None of us have we're not lobbyists. Like I have to do my work at my actual job most of the time. Everybody else was either like a person with lived experience or somebody who works at a program. So that's really how we got this done. You have it, thank you. So where are we at today? Vermonters for Criminal Justice Forum were chosen to run the Burlington OPC. They're a very small SSP. They have literally 3 staff members right now, and that includes the executive director. The executive director wanted to be here with me today. We applied to speak together. He's not here because we literally won yesterday, and we needed him to stay back in the States to make sure that we actually got where we needed to be, but he's an amazing guy. He worked at the health department 2 decades ago. Nobody wanted to let him do SSPs in the city, so he quit and started one anyway, ran it for about 20 years, left. Things kind of went bad when he left, so he started Vermonters for Criminal Justice Reform, and all of his staff just followed him to the new place. Most of the people working there have lived experience, have been working in Burlington for over a decade, giving out syringes. They have the trust of the community. They know how to do this work, but the health department hates them. So they're desperately underfunded. They weren't even allowed to be a syringe program until the bill we were talking about passed. It's not my focus here, but we also expanded what it takes to become a syringe program, so it's much easier to become one in the state. Doubled the funds of all 4 syringe programs that existed, and I think made enough budget for like 2 or 3 more programs to open, which was not what we talked about, but was a big part of the bill that I'm excited about as well. So then the Vermont Department of Health got to write guidelines. We wrote the bill specifically to make sure the Department of Health had basically no decision-making power because they hate harm reduction. So we wrote the bill that they are allowed to make the guidelines, but not actually have anything to do with who gets to be the program. any city in the state of Vermont could open a program right now legally. It's just the city has to approve it. So we were trying to get one in southern Vermont, and Brattleboro City Council balked and did not vote for it. Burlington, however, was willing to do it. So they wrote their first set of guidelines. It was a little too high threshold. We pushed back. Still a little too high threshold. We need a doctor and some nurses, but we got what we got, and it's a thing, and it's great. So as long as you agree to follow the guidelines, you're allowed to be a program if the city council votes for it. So the city council had already approved it. The mayor appointed the program months ago. And the last step literally happened yesterday. I wrote these slides just assuming it was going to be true. But because we packed the opioid settlement committee with people we trust, we got the opioid settlement committee to dedicate $1 million per year for our program for the next 5 years. But yesterday, the city council had to decide whether or not to give us that money. And the city council has flipped a bunch of seats since the last time. However, we got unanimous support from city council. I have to believe that we might be the most pro-OPC city in the whole world, because every single person on city council, the mayor, the police chief, the fire chief, not every person in the city, but everybody in power in the city agreed that we should be opening an overdose prevention center, while harm reduction is being villainized across the entire country. Oh, and that looks like these. So what is next? Well, we need a location. Burlington is a very, very expensive city. It's going to be, and as I keep saying, our downtown's very small. It's going to be hard to identify a spot. Luckily, the mayor and city council have agreed to basically waive any zoning that it takes to waive to get this place into downtown. The one zoning we said is we can't be too close to a school. There are 2 schools downtown, so it might be slightly a challenge, but if anybody wants to give us like $1 million to buy a duplex, we'll be set for life. There's probably like 1 million of them right where we need to be, but they probably cost about $1 million these days. New staff need to be hired. This program has basically just tripled its budget overnight. 3 people are not going to be able to run an overdose prevention center, so new staff need to be hired. A thing that went a little interesting for us, we had advocated for the right to open a smoking room, and it ended up in the guidelines that we need to open one within a year, which is a logistical challenge because we have no capital money to actually build one. And I'm not even totally sure how we have to do it because the regulations aren't clear. So it's a good thing, but it's definitely a thing we have to figure out. We can't open and just not do that, which wasn't the goal, but still challenging. And let's be clear, the US is going super fascism. We're definitely going to need to get legal support because we're almost definitely going to get messed with by the Department of Justice. Luckily, unlike some other places, we do have state and city law protecting us, and maybe a third of our economy runs on weed money anyway, and that's already federally illegal. So I'm not kidding. There are 12 weed stores in that 10 blocks of downtown. Man. So last slide, please. So thank you for attending this workshop. Thank you for HRI for letting me come to speak about this. My last words are, you just got to keep advocating. We got lucky. You advocate, you wait until your political moment, you teach everybody what you need to do, you educate them year and year, and one day something hopefully goes your way, and then you win. And it's somewhat luck, but it's persistence. You keep being persistent until that moment hits, and then you're able to win. That's what I got to say.
Thank you, Mike, for this approach and to let us know. I want to highlight also how it makes a huge difference of acceptance of harm reduction, the privilege, no? And we have to see the colonialism behind that and the racism that is there. In Catalonia was the same. The acceptance 30 years ago was really because who were dying also were the brothers and the kids of the politicians. It was not about right or left. It was about feeling that, and how is incredible that, and this is why the Black, indigenous, brown communities are more impacted, no, for the death of that. Then thank you for highlighting that, and congratulations, and good luck with the new challenges, and with this crazy guy. And also I want to mention Harm Reduction Coalition, because you make us learn a lot every time that we come and stay in your conference, then thank you for that. And I just gonna go to Samuel San Rivera, that he doesn't need introductions for sure, but the executive director of On Point, New York, the first legal supervisor consumption room in the States, holding that huge responsibility. So.
I'm still writing my thing. Good afternoon. First of all, I want to congratulate Vermont. Congratulations. It's a big victory. It's pretty amazing. Yeah. Ours wasn't so sweet. Still isn't, but it's going well. I'll first mention again, if you've heard me speak before, my inspiration, my mom. Without her, I wouldn't be nowhere near doing this work. So quickly, at On Point, we say we are the medicine. And we believe in that as Native people, we also Indigenous people, like we are the medicine for people. And even if when you're administrating naloxone, it still takes a human to do it, right? So you participate in that medicine, which is why we use that term and that concept. So I'll go over a few things and talk about a process and really run fast so I could get this done in 10 minutes. So 85% of our staff are people with lived or living experience, which is very important to our work and our mission. As many of you already heard, I was a young member of ACT UP, which really guided me in many ways to do this work in the way I do it. And one of the things I would always tell people about my time at ACT UP was, before ACT UP, I was in a penitentiary. I wasn't in a correctional facility because I don't even know what a correctional facility is because they didn't correct shit. But I was definitely in a penitentiary. And so in ACT UP, we would act up and we would fight and do all these things. And then oftentimes we got to a point where we would get arrested. And that's when I would say, all right, everybody, arrest for you is cute. For me, arrest kicks up a lot of experience. So I'm going to go home and I'll meet you in the morning with some coffee and donuts. But I will not be getting arrested today. And I bring that up because when we decided to open the OPCs, one of the first things the board said, my board at On Point, was, are you ready to get arrested? Which is probably very likely. And this was one time in my life and in my work where I said, okay, I am ready if that were to happen. And so far, it hasn't happened. And I don't believe it will. I don't move in that energy to think that something negative is going to happen. I would say harm reduction is the epitome of meeting people where they are. In our work, we have so many people using that term now, right? We meet them where they're at. A lot of it is bullshit because you meet them where you're at, but you can't use. We meet you where you're at, but you have to do this. So there's a but in there. And so that doesn't actually mean that to me. And so in this country, there's no war on drugs. There's a war on drug users. In the U.S., there's no war on drugs. There's a war on drug users. In fact, there's a war on specific drug users, black and brown primarily, black and brown and poor white. And what we have is specific drugs are allowed to go to specific neighborhoods. Those people use and sell those drugs and are punished for doing so. And so what we have is what I call modern day slavery, where we look at the system of people going through that system, supporting the U.S. by bringing money into the injustice system. I've been in harm reduction a very long time, and I stepped away for a little while. And I did because I'll speak for myself and some of my colleagues. We had one tool. I felt like we had one tool. Every time we went somewhere, we whipped out a hammer, and we beat you over the head until you supported us. And for many years, we had to do that. Like we had to really fight our way into rooms. And I said, if I'm going to come back to harm reduction, I want to try to move in love. I want to move in a very different way. And I remember after talking to the staff at On Point about that, and they all said yes, is after I got the job, they said, well, we just said yes because we wanted you to take the job. And I was like, oh, shit, all right. But then we started to do it. Like we really started to do it. We started telling our funders, we're partners. I'm not scared of you. I'm not here to perform for you. We're partners. If I fail, you fail, right? So how do we work through this work to make sure we do it in the best way possible? I always say also listen to people who use drugs and sex workers. And we have 2 ears and one mouth. Most of us have 2 ears and one mouth. So listen twice as much as you speak, especially when you're getting suggestions and advice from people with lived experience. Last year, the U.S. had this party for celebrating a 10% drop in overdose deaths, which I think is pretty sad. right? First of all, the data is is extremely messy, and especially because during this time, Black and brown communities saw an increase in overdose deaths. So I ask you all, and especially those from the U.S., is watch what you celebrate, because we still experience over 100,000 deaths a year. So on November 30th, 2021, we opened the first 2 overdose prevention centers in the United States. And it was pretty amazing. And I want to be clear as to why we say overdose prevention centers. We've called them safe consumption rooms. We never call them safe injection because our sites are polymodality. We have large smoke rooms, injection, all the options exist. And then quite frankly, in meeting with some federal folks, we were really doing a good job negotiating off the record. And one time I said overdose prevention centers, and they said, could you just keep saying that, please? Because we like that one better. It's a little nicer. It's a little softer. So we agreed, right? Let's use a language where we can stay in the safe lane for now. So I want to quickly point out someone. When we first opened OPCs, we had our first staff, and someone is here, and she's a very young woman. Ella, please stand up so people can see you. They're probably surprised, like, so feel free to ask her questions, right? Like, how did this kid work in the overdose prevention center? She's a pretty badass and responded to many, many overdoses in your time in the OPC. Why did we open? We opened because we had a responsibility to respond, to really support people who use drugs in the neighborhoods we provide services. And how did we open is always interesting, because we didn't go through what a lot of people have gone through and are close to opening, or what people think we went through. So oftentimes I get calls from people and they say, so what politicians did you talk to? What was your process like? And I'm like, okay, wait a minute. We didn't do any of that. We had a mayor who was leaving in a month, and I didn't really care about his motivation. People told me, oh, he's just doing that to get people back. We didn't support him in 2018. All of those things didn't matter to me. What mattered to me is we had an opportunity to open. And so we had the mayor, and then a lot of negotiation in only about 2 months. That's it. It was like, open now. And it was back and forth, and there were calls every day and night. And in the interim, we were building out a space, not sure if we were going to open an OPC. So we had this space with 4 bathrooms in it. Wonder why we have 4 bathrooms in it. I remember the landlord saying, Sam, you need 4 bathrooms in this little space? I'm like, yeah, people use the bathroom a lot. But then, he really became a partner. I said, well, this is why we need so many bathrooms. And he was excited, and that was a blessing. And both our landlords in both buildings have been partners in this work. And that is a way where a lot of government agencies attack and communities will attack your landlord to see if they can stop you from operating an OPC. So we had the support of the mayor, and then we had an incoming mayor, Mayor Adams, and we weren't sure where he was going to land with this. And I said, do we open for a month? And we said, well, maybe a month is what we do. Let's see what happens. And advocacy really matters, and our partners at Vocal kept going after the mayor coming in, going after him, and one day he tweeted his support for the OPCs. And it was mind-blowing. It was a major victory for us. So we had the NYPD, and we still have the NYPD as a major partner. A little strange sometimes talking about it, but it's real. And I think one of the mistakes we make in our work as well is we don't, we get stuck on everybody else's opinion about how to make things work. Yes, we partner with the NYPD to the point where in the beginning it wasn't cute or sexy. It was challenging. And our staff would go to roll call in the morning and meet with them and tell them, this is the way it's going to work. You will not stop anybody walking into our building. You know why some of them are walking in. We also made sure that they understood that not everybody coming into the building was coming in to use drugs. The other thing is, what happened pretty quickly was mind-blowing. They came to us and said, we have an issue. We're trying to talk to you, people in the community who are about to use drugs, and they think we're going to arrest them. I said, of course they do. So they said, can you make cards for us to show our partnership? And it blew our minds. Like, they asked us to make these cards, and they gave us the language. We're here to support you. We want to take you to On Point. It was shocking, and we still have that support. The other side of it were the DAs. We have 5 DAs in New York City. One of them lives in Staten Island, doesn't count. And so the other 4 DAs signed on to support OPCs. And it's a big deal because the other side of it is if law enforcement decides to arrest people through this process, the DA is already telling them, we will not prosecute, we will not move forward. In fact, we will tell them to go back to On Point, which was really exciting. Our landlords, as I mentioned, were very supportive and still are. I also had the ability to sign 2 30-year leasehold condos. And in New York City, what that means, it looks like we owned the building for 30 years. And I did that because I was worried about the landlord changing their mind one day and coming in and trying to evict us. So we're clear for another 28, 27 years or something like that. So when we opened, we put candles at every booth in honor of those who weren't able to be there, people we lost. And it was just a ritual we wanted to do. We put candles the night before and let them burn throughout the night. And it was really a beautiful moment. My mom, I used to visit my mom at the hospital as a kid a lot. I was a mama's boy. And on the Lower East Side. And she was one time working with this guy who used drugs in the emergency room. And he was there 3 days in a row. And I said, Mom, why do you keep helping this guy? And she says, I'm going to help him until he's able to help himself, which led me to come up with this term we use at Fortune is at Fortune, my old job, at On Point, which is we love on people until they're ready to love on themselves. And we really move in that energy, and we see that also in harm reduction in that way. So what happens in the room? Kaylin C. used to say, the least interesting thing in the room that happens is the drug use. Not that cool. The fun thing in the room is the community, is the loving on people, is the music that plays, is the fun, is all the things that create a space for people who are used to using in a rush, in an alley somewhere, unsafe very quickly. Now they're sitting down relaxing. They have as much time as they want. They get to talk to each other, have a good time. Many of you heard me say this, but I thanked Will Smith for smacking Chris Rock for a long time because in the room they used to argue about why it happened. And what would happen is Will Smith participated in the reduction of drug use because people would be like, well, I can't use my second bag or I can't use more because I got to give my opinion as to why this smacking took place. And we see that with sports and music, a bunch of things in the room where people are having healthy disagreements. What happens during an overdose in the room is very different than what happens in the street. Someone in the street has an overdose. People take their phones out, they record them, they make fun of them, they call them all kinds of names. In the room, if you have an overdose, we call you by your nickname. We call you in loving terms. We respond with love, and we use, if we use naloxone, we use 0.4 milligrams of naloxone, what we call microdosing. In all the overdoses we've had, we've only used naloxone 18% of the time. 18% of the time is pretty amazing. We have an amazing oxygen protocol, and I'm glad that we're talking about this in this international gathering because it's not our protocol, right? And even when we opened in New York City, we didn't feel like On Point opened. We happened to be the organization. All of us in America who fought to have one OPC for many years open. It was a celebration of everyone. It was a celebration of people we lost. So it was important for us to communicate to our colleagues that this wasn't our victory as On Point. It was everyone in harm reduction in America who opened the OPCs. We have, finally, this is my one slide, is our model of care. And this is important. This has become a really important model in discussion because people think an OPC is the only thing you do. It's the only thing we're known for. And look at all the services we provide, right? We're a well-rounded, multifaceted harm reduction organization. So when you come into On Point, people open the door and they go, where's the drug use? Like they thought we were going to walk into this drug-using orgy in the middle of the drop-in center. And when they walk in, people are having coffee, people are watching a movie, they might be eating something and hanging out. The OPC is in the back. It has its own space. We have, and the organization really was founded by the Black Panther movement through acupuncture and auricular acupuncture many, many years before, as we were moving into harm reduction. So you look at all of the services we have, and for us, our entire process is about wellness. How do people get well? And if for them that means the reduction or the elimination of using drugs, that's for them. We don't tell them that. What do you need to get well? And what I know in my 35 years of this work, 35 years. I was 12 when I started, so do the math. Yeah, somehow I came out of a penitentiary. But anyway, 35 years of this work is people start to change their lives, and our people we work with, when they start to build a relationship with themselves and feel comfortable and feel seen. For some of them, it might be that one shower. Something happened. It might be the meal they ate. It might be one visit with one of our nurses or one of our doctors. Oh, you cut me off? It's time? No. Yes. Okay. It's time. Damn. Let me see if I can just add a few things. But again, for most people, that time happens. You know, it's so interesting how everybody says, just send your people to treatment. We have over 6,000 participants. They have all been to treatment and detox multiple times, all of them. So when they ask me how many people did you send to treatment, I'm like 100%. How about that? How's that sound? So I'll quickly just give you our numbers and wrapping up this, what I thought was I was going to get done in 10 minutes. We opened again 3.5 years ago. Since we've opened, we've had almost 6,400 registered participants in the program. The community asked us why we opened. I said, I responded to your request. And they said, I didn't ask you to open an OPC. I said, but you did. You said you didn't want syringes and hazardous waste in the community. You didn't want people using in your community. You didn't want people using in parks where children play. You didn't want all these things, and we agreed with you. The difference was you wanted us to get rid of the people. And what we did was bring them inside and love them. And that's where we disagreed. But I responded to your request. So we opened again 3.5 years ago. We've had 200,000 utilizations. 200,000 times people, instead of using in the community, used inside with us. And during those 200,000 utilizations, we're close to 2,000 overdose interventions. 2,000 times our team responded to overdoses in those rooms in the most amazing ways. Teams, staff members who are trained to respond to an overdose at the level of an RN. In New York City, it costs about $30,000 in the community to respond to an overdose. $30,000 for each overdose. We've had, again, almost 2,000. All of you have smartphones. Take away roughly 100 where we interacted with some other folks to support us, not with the overdose, but with other medical conditions. So let's say 1,900 times 30,000. That is how much money, over $50 million, we've saved just two New York City neighborhoods in 3.5 years. It roughly costs $3 million to run a 24-hour OPC in America. So you do the math and let me know if it works. Lastly, drug use doesn't define us. It's something we do. It's not who we are. Thank you.
Thank you so much, Sam. Yeah, of course, I think that we know that the last thing that happened in the consumption room is the drug use, no? I think that for most of the people, it's the only moment in the day that they don't need to think about drug use. They can challenge all their other things then, and how privileged we are when we can be there, no? And enjoy that moments with them. And also the importance of the stakeholders, and we know that we are full of negotiation, agreements, finding the ways to go there, then we need to be creative, and thank you for all the work that you are doing. And last but not less important, I want to introduce Maria Angélica Comis, that is a good friend. We have met, I don't know, for over 15 years, fighting for the same fight. No, Maria Angélica is from Brazil. She's the coordinator of the Brazilian Network for Harm Reduction and Human Rights, REDUC. And she's going to explain us the different advocacy strategies for implementing safe drug use spaces in Sao Paulo. I know that now she's in a new venture, also implementing a lot of different services on harm reduction. Then please, this overview.
Thank you. Good afternoon, everyone. I would like to thank you for being part of this discussion panel with people I admire. Over the last 15 years, I have been working and fighting for harm reduction, especially with the most vulnerable people who use drugs. Always dealing with precariousness and few advances in drug policy in Brazil. We continue to try to be bold in a conservative and moralistic country. This presentation, titled Building a Safe Use Space Policy in São Paulo from Listening to Legislative Proposals, outlines a strategic and participatory process developed over the past years. That's why I will begin by explaining some of the steps we have taken to try to building an institutional path that allows us to create spaces for safe use in states with 4 million inhabitants. So, our fight is against this situation, this largest drug scene use of São Paulo, Brazil. A lot of violence and vulnerability and a lot of racism and machismo, etc. We began in 2022 with the creation of technical working group, within the Municipal Council on Alcohol and Other Drug Policies. This group brought together health professionals, social workers, harm reduction specialists, representatives of civil society, and people who use drugs to formulate proposals based on scientific evidence. This initial result was a technical document to support this institutional debate. In the same year, we produced a technical note addressed to the mayor, consolidating legal, health, and social justifications for the creation of safe use spaces, aimed to formalize the proposal and include the topic in the public agenda. In 2023, we hosted the 80th Municipal Conference of Drug Policies, a large participatory event that involved pre-conferences across the different regions of the city, culminating in a municipal conference with nearly 1,000 participants. The conference reaffirmed that harm reduction should as the center pillar of municipal policy and endorsed the proposal for implementing drug safe use space. Following that, we expanded our articulation for forming an interinstitutional working group, bringing together the human rights committees of both the São Paulo City Council and the State Legislative Assembly. Parliaments committed to human rights, local residents from the territory, with the largest open drug use scene in Latin America, and civil society organizations, especially in harm reduction. The goal was to build consensus, adapt the proposal to local realities, and address potential resistance. And in 2024, a bill was filed to establish a state harm reduction policy. This bill is currently being processed by the Penalty Committee, which is the Health Committee. We have also begun drafting in the state bill to authorize the creation of safe use spaces across the state of São Paulo. Based on the Brazilian Constitution, which allows states to legislate on health matters, Article 24. This initiative demonstrated innovation, even the absence of a specific federal regulation. This bill is currently being processed by the Justice Committee in the Legislative Assembly. So, and in 2025, we filed the state bill. The project achieved major media repercussion. The topic gained wide visibility, generating political polarization, but also opening space for a broader public debate. We are still trying to build more space for dialogue on this topic, precisely to deconstruct myth, and stigmas, and expand dialogue with civil society and political sectors. In conclusion, today we seek to consolidate new partnerships and gain broader support for different spheres of government and civil society. It's essential that we have more stakeholders discussing the proposal so that social mobilization continues to grow, reinforcing the central message that has guided us from the beginning. So, the right to health, dignity, human rights, and life is no negotiable. Sorry. But we continue to try to build in public policies that care for, respect, for transform people who use drugs. Thank you very much.
Great. Thank you, Maria Angélica. It's always a pleasure to listen for your experience. I don't want to take more time because I want to use these 5 minutes for you if you have any comments, questions. Hans? Andrew.
I want to thank you all for the amazing work that you're doing. And maybe just to state the obvious, but I think it's worth underscoring. Harm is not, I mean, the services that are provided are the conduit for the healing experience that happens in the relationships, in the community, and in the spaces that you've all built. And I just, that's so powerfully illustrated by, I've forgotten your name, but doing the work in the hospital, that just having a safe consumption site in a hospital contributes to increased entry into treatment and recovery. I mean, it's just mind-blowing, but, it's just, I just appreciate the work that you're all doing so much. Thank you so much. I've done a little bit of work. Andrew. Tatarsky.
Nobody else? We are super tired, no? Okay, let's go to the party.